Okay, now we're going to talk about Chapter 12, the primary assessment. Of course, the topics is the primary assessment. Okay, so the entire job of the primary assessment is to focus on life threats, which means we're going to find life threats and treat them. And we will never move past that until we get them treated. So sometimes the entire call that you're on or run will be focused on this primary assessment and taking care of life threats, right? We start talking about primary assessment. We'll talk about ABCs, the airway, breathing, circulation. Um, and these may vary depending on the patient's condition, how many EMTs are on scene, and other priorities determined as you assess the patient. Now, our normal order on our patients are going to be A, B, C, depending on initial impression. So if we have a patient that has signs of life, we'll go airway, breathing, circulation. That's how we'll check it. However, if they're unresponsive, like lifeless or no pulse, it'll be CAB, circulation, airway, breathing. So we'll start CPR with compressions. And then we'll do our open airway, then we'll do our breathing. Immediate interventions may be needed, like, for example, um, life threatening bleeds, right? Any vomit in the airway that enters the lungs is very serious and often fatal. It causes an aspiration and later on an aspirated pneumonia, and it can be very, very fatal. So, we have anything in our airway, we're going to have to suction it. Big life threatening bleeds, they must be stopped immediately. Uh, because if we bleed out, there's no sense of having an airway or breathing when they don't have any blood, right? Breathing and circulation are obvious vital for life. So we have to make sure your patient is breathing and breathing is adequate enough to support that. If not, we're going to fix that. We're going to help them. Decision making in the primary assessment. If an immediate intervention, such as bleeding or CPR, is required, um, we're going to shift into the important but less urgent mode in which you administer oxygen appropriate for the patient's condition and evaluate for shock. So let me rephrase that. If immediate intervention, so if they don't have a life threatening bleed, they do have a pulse in their breathing. So we're going to shift to an important but less urgent mode where we're going to put in oxygen if appropriate for the patient and evaluate for shock. In our primary assessment, it's broke down into 6 different divisions or steps. And those are 4-minute general impression. So we're going to get a general impression. We're going to assess their mental status. We're going to assess their airway. We're going to assess their breathing, assess their circulation, and then we're going to determine their transport priority, right? And we'll talk about that in a little bit. 4-minute general impression. This is assessing the environment and the patient's chief complaint and their appearance. This is what we call the across the room appearance. What does your patient look like when you walk in? This will also help determine the patient's severity, right? So if someone's unresponsive or unconscious, we're going to step it up a little bit. But if they're sitting there and they look at us when we walk in and they're pink, warm, and dry, maybe we have time, right? It helps set the priority for care and transport, what I just talked about. So if we're forming a general impression, includes your initial assessment of the environment, chief complaint, and appearance. This young lady looks like she's got some injuries, but she is pink, warm, and dry. Her eyes are open. Looks like she's breathing. So we have time to evaluate. Beginning spinal motion restriction. Treat the life threat conditions while not aggravating the potential spinal injury. We're going to apply SMR, which is spinal motion restriction, to the head by a manually holding the head and neck on first contact with anybody who's got suspected injury, right? If we have a suspected spinal injury, I'm going to go up, someone's going to go up, take manual C-spine, or we're going to control that C-spine manually. You're going to continue the SMR throughout the call unless the physical Examination determines not necessary. So we have someone who's unresponsive, looks like they fell. I'm going to go take manual uh, stabilization. We're going to place a C-collar. We'll log roll them onto a spine board. We will secure their head to the board via head blocks or other mechanisms. And then we're going to, at that point, I can release the manual stabilization. That's the only time I can. The manual stabilization holds the head and neck in that neutral inline position. Um, there is more than one way to restrict motion of the spine during the primary and secondary assessment. And your EMS system has specific guidelines of when and when not to use a stabilization and spinal motion restriction. So your protocols will outline that. The look test. Get any feeling about a patient's condition from environmental observation as well as the first look at the patient, right? This is what I talked about, the across the room look. This can identify patients who may be critical. If they appear lifeless, resuscitation will begin with CPR compression and prepare an AED as soon as possible. Patients who have an obvious mental status, altered mental status, and patients who appear unusually anxious, and those who appear pale or sweaty. These are all patients that could be critical. Obvious trauma, the head, neck, pelvis, or abdomen. Certain positions like the tripod. We all know what the tripod is. That's where they're leaning forward, their hands on their legs. That's a sign that there's obvious difficulty breathing. Or Levine's sign, that's where they're holding their chest with their palm or their fist in the middle of their chest. That's the Levine sign. And it's a chest pain or discomfort. Could be a sign of something really serious, like an MI. The chief complaint. This is why we were called. You know, when we go up there and introduce ourselves, what's going on today? Well, I'm having chest pain. So chest pain would be your chief complaint. Now, just remember, the chief complaint is not always the same as what we were dispatched for. We may be dispatched for difficulty breathing, and we get there and the chief complaint is chest pain. And it may be specific, like I have abdominal pain or chest pain or my legs hurt, or maybe be very vague, not feeling good. We have to get more information. With the chief complaint, we're going to form an impression of the patient by look, patient's age, or sex or position, listening, moaning, snoring, or gurgling, or smell, hazardous fumes, urine, feces, vomitus, or decay. So following the chief complaint comes that we're going to assess their mental status. We use the APU scale, and the A stands for alert. We're going to document an oriented to person, place, and time. So we're going to ask them a few questions like, what's your name? What's today's date? Where are you at right now? We go the extra into a fourth, and it used to be who's the president, but I don't ask that anymore. I ask how many quarters in a dollar, right? They can answer all these questions. Then we document that they're oriented times 4. Now, time is a little bit, there's a little give there. If I ask somebody what's today's date, they may not know. Ask them what day of the week is. Again, they may not know, right? A nursing home patient or may just not know what today is, but they may know the month. They should know what season possibly. So if we go and they're not awake, but we go talk to them, like, hey, you, and they open their eyes, we list them as their mental status is the verbal response. If they don't open their eyes when we say, hey, you, and we give a little tug on the shoulder, pinch their ears, whatever, and they open their eyes, we call that a painful response. So they'll respond to painful stimuli. And if they don't respond to any of those, they will be classified unresponsive. Once we've assessed their mental status, the next step is assessing their ABCs. And this will depend on the patient's condition, right? We talked about it. If they look alive, we're going to start with the airway and breathing circulation. If they don't look alive, we're going to start with circulation, airway, then breathing. We're going to identify and correct any life threats at this point. If they're not breathing, we're going to breathe for them, right? Don't have a pulse, we're going to do compression. Any major bleeds, we're going to fix. Any obstruction in the airway. These are all life threats that we have to fix at this point. And we'll continue working on this until we either fix it or we get them to the hospital. Gather information that'll help you for later on in your assessment. Here's a picture. We're going to look for signs of life, including movement. Scan the chest for breathing. If no signs of life, as in breathing or gasping air, are found, check for a pulse. Airway. If a patient is alert and talking clearly or crying loudly, they have a patent airway. If the airway is not open or it's endangered, we're going to have to open it. And we're going to have to clear any blocked blockages. We've talked about that in the last few chapters, right? We can suction, maybe to help clear out the airway. We can do the abdominal thrust, chest thrust, and finger sweeps if we have to be. Breathing. Sometimes we're going to have to assist their breathing. And some of those situations would be if the patient's in respiratory arrest with a pulse. If they're not alert with inadequate breathing, which we talked about last chapter, have some level of alertness with inadequate breathing, has adequate breathing but signs suggesting they're in respiratory distress or hypoxic. The first three here, we're going to BVM, use the BVM. We're going to bag them. The last one, we maybe get away with just putting them on some supplemental oxygen. Maybe that'll help. Okay, circulation. We're going to assess the skin, right? Good circulation. Pink, warm, and dry skin. It's a good sign. Signs of shock. It's pale, clammy, which is cool and moist skin. Diaphoresis, which is really, really sweaty. Like when they're this time of year, if you're really, really sweaty, it's not a good thing. Here they're checking a crowded pulse for no longer than 10 seconds. 3 results of assessing a pulse. Is it the heart rate within normal limits? Or is it unusually slow? Is it unusually fast? We're going to check for and control severe bleeding. Next comes determining priority. We have 2 priorities. It's a load and go, which is a critical patient, or as we call it, stay and play, where we have time to do further assessments and maybe some treatment. So we're going to treat any life-threatening ABC problems as soon as possible it's discovered. To be considered stable, patient needs to have vital signs that are normal range or just slightly abnormal. A threat to the airway, breathing, or circulation, either actual or imminent, rules out stability. So if there's a threat to the ABCs, either actually a threat right now or something that looks like it's going to happen soon, imminent, or it could happen, we're going to rule out them being a stable patient. And unstable patients are high priority. No pulse to begin compressions. There are times that when it may not be crystal clear what the patient's problem is, so there will be many possible diagnoses, and some are more serious than others. Good example is like abdominal pain, right? It could be as simple as stomach flu, or it could be something as major as internal bleeding or ruptured appendix. I mean, it could be a bunch of possibilities. And remember, the patient's priority could change, right? It could be appear to be stable, and then all of a sudden they're no longer stable. Like their breathing becomes inadequate, and we got to breathe for them. So, there's all kinds of possibilities. We just note that we can change their status from stable to unstable at any point. Initiate priority transport on a life threatening problem that can't be controlled or treated or threatens to reoccur, or we can't really do much for it in the field, or if the patient has a depressed level of responsiveness. So if they're verbal response, painful or unresponsive, this is a depressed level of responsiveness. We'll continue assessment and carry it out. So we just won't stay around and play. This is a good question. Well, why must you continue to reevaluate the primary assessment? Okay. Why? Because it could change, right? We just talked about that. We can have a stable patient and we keep reassessing for life threats, and we find a life threat, like all of a sudden their airway become obstructed. Okay, so now they're no longer stable, they're unstable. Patient characteristics and primary assessment. The assessment takes different forms depending on certain characteristics. The patient may have a medical problem or trauma, right? The patient may or may not have altered mental status. The patient may be an adult, child, or infant. These are all different characteristics on how, and they're differ in how we do our assessment or our forms of assessment. Chapter review. The primary system is a systematic approach to quickly find and treat immediate life threats. That's the entire job of the primary assessment. This includes a general impression, although subjective, can provide extreme useful information regarding the urgency of a patient's condition, right? So if I walk in and I see somebody sitting in a chair, kind of lean forward, their fist is in the middle of their chest, they are very gray looking, they're diaphoretic, that's important. That's a general impression that tells me this patient's fairly sick or in trouble, right? More likely that would be cardiac, maybe having a heart attack. So after we form a general impression, we're going to assess their mental status. And we do this using the APFU scale. Alert, verbal, painful, unresponsive. We're going to evaluate. Our next step is to do our ABCs quickly, but thoroughly. Where we're really immediate life threats and must be treated before further assessment. So, like I've said that before, if we find a life threat, we fix it before we move on. And what are life threats? Inadequate breathing, an unopened airway or unpatent airway, a weak pulse, severe life-threatening bleeds. These are all life threats. Your approach will depend on how the patient presents. The AHA recommends CAB approach for patients appearing lifeless or apparently or not breathing and have any agonal respiration. So we're going to start with chest compressions or CAB, the circulation part. We're going to feel for pulse, down pulse, we'll start compression. If they show signs of life, we're going to switch that and go to the traditional ABC approach. So we're going to make sure they have an airway or patent airway. We're going to make sure that they are breathing. If they're not, or it's inadequate, we're going to breathe for them. And then finally, we're going to move on to if they have a pulse or any life-threatening bleeds. You choose your interventions based on patient's immediate needs. So if I walk up and I see a major life-threatening bleed, I may go ahead and treat that first, or you're going to treat that first, because it doesn't matter if you have an open airway, they're breathing and they have a pulse. But if they bleed out, it ain't going to matter. Patient's priority describes how urgent the patient needs to be transported and how to conduct the rest of your assessment. So if they're an unstable patient, we're going to classify them a load and go, and we're going to do our other assessments and our treatment en route usually. Now, if they are a stable patient, we have time to assess them. We may do some treatment on scene before we get them loaded and go to the hospital. Determine if they're responsive or unresponsive, whether they're adult, child, or infant. Rapidly identify the need for immediate airway intervention. Determine the patient's condition is stable enough to allow further assistance or treatment on the scene. We just kind of talked about that. The first two would be a load and go, and the second would be a stay and play, or stable and unstable. All right, that's it for this chapter. We will see you on the next one.